Good afternoon, and welcome to our live stream on peripheral arterial disease, also known as PAD. We appreciate that you've taken the time to join us live or via our recording. My name is Ann Luciano. I'm a nurse practitioner with the PAD multidisciplinary program at the University of Michigan. September is PAD Awareness Month, and as with any awareness month, we wanted to take the time to increase public knowledge for PAD. In the next hour, we hope to discuss the diagnosis of PAD, risk factors, symptoms, and available treatment options to improve early detection and prevent serious outcomes such as amputation. PAD affects between 8 to 12 million people in the United States annually and is often overlooked or misdiagnosed. We are fortunate today to have three of my University of Michigan Health colleagues and PAD experts with us. Dr. Khaja.
Thanks, Ann. My name is Minhajuddin Khaja. I'm a vascular and interventional radiologist and a member of our multidisciplinary PAD program.
Dr. Patel.
Thanks, Ann. My name is Nimesh Patel. I'm one of the vascular surgeons here at the University of Michigan and once again a member of the multidisciplinary PAD program.
And Dr. Grossman.
Thanks, Ann. Good afternoon, everyone. I'm Mike Grossman. I'm an interventional cardiologist and have been part of our multidisciplinary peripheral arterial disease program for many years. Very happy to be here.
Before we start, a few housekeeping options. If you're watching this live, you're welcome to submit questions at any time. We will pick some to be asked during today's chat. Questions can be submitted by commenting on this video on whatever platform you are watching on. But please note that your name or profile name will be visible to others who are participating. If you prefer a more anonymous option, you can send a private message to us via the Facebook direct message function on facebook.com/Michigan Medicine. We know there may be many questions, so we may combine some that are on the same topic. And please know that our experts cannot give specific advice for any individual situation you might be facing. If you can't stay for the whole chat or wish to share the recording with a friend, you'll be able to watch after the live stream ends via the Michigan Medicine YouTube channel. All right, let's get started. Dr. Grossman, what exactly is PAD?
It's a great question. Obviously, it's why we're all here. So peripheral arterial disease is essentially buildup of cholesterol or atherosclerotic material in the blood vessels that are feeding blood to our legs. It can be minor buildup of blockage all the way to complete occlusion or blockage of the blood vessels that are feeding blood to the leg. And the more severe the peripheral arterial disease, the more likely patients are to have symptoms associated with peripheral arterial disease.
Thank you. Dr. Patel, what kind of physician teams treat PAD?
Multiple specialties can treat PAD. First-line therapy for mild disease is just medical therapy and a walking regimen. And a lot of that can be managed by your primary care physician. However, if disease progresses and you get worse and worse symptoms, there are specialties like those present here that can help. For example, we have Dr. Grossman and Dr. Khaja, part of interventional cardiology and interventional radiology, respectively, that can perform advanced maneuvers with endovascular techniques. And then vascular surgeons like myself that can do that, as well as open surgical techniques like bypasses.
Dr. Khaja, what are the common tests that are used to diagnose PAD?
Thanks, Ann. So we have a wide range of tests that can be used to help diagnose peripheral arterial disease or PAD and figure out where maybe that blockage is. The easiest of which is an ABI or an ankle brachial index. It's really a painless, quick blood pressure test that compares your blood pressure in your arm to that in your legs. And it can sort of show us very simply if there is a patient who has a blockage somewhere in their legs. If we feel like there is something there, we can use another test with ultrasound that uses sound waves in order to show us where there are narrowings or blockages and kind of give us an idea of how severe the disease it is. And they're, again, very non-painful, very easy to do tests. If we want to figure out a little bit more anatomic information, where the blockage is, how bad it is, and maybe how we're going to treat it, we could move on to something like a CT scan with dye. In this case, dye is injected into a vein, and then a CT scan is performed using X-ray in order to figure out where the blockage is and sort of how bad it is, as Dr. Grossman mentioned. And then finally, you can do something with an MRI, which is a non-X-ray version of getting these images. Similarly, we inject dye, and then we get an MRI scan, and that can also show us where the blockage is and potentially how we can treat it.
Dr. Grossman, is PAD serious?
I've got to get serious by appropriately unmuting myself, but PAD can be a very serious condition. As was mentioned by Dr. Khaja, patients with more advanced disease can have severe blockages in the blood vessels feeding their legs that can result in discomfort or pain when they're walking or exerting themselves, can lead to ulceration of the lower extremities, and worst case scenario can lead to infections and potentially even the need for amputation. In addition to that, any amount or any severity of peripheral arterial disease is a marker for atherosclerotic disease throughout the body. So that may mean that a patient with PAD is also at higher risk for coronary artery disease and potentially heart attack. It also may mean that they're at increased risk for buildup of cholesterol in the carotid arteries, which can be associated with stroke. So PAD is a very serious condition. It can not only lead to loss of function and amputation in worst case scenarios, but again, it's a marker for more advanced global atherosclerotic disease that needs to be treated aggressively.
Thank you. Dr. Patel, can PAD be cured, or is this something that patients will have to manage long term?
So unfortunately, PAD cannot be completely cured. It is a chronic condition, and it will be something that you continue to manage long term. However, you can slow its progression with exercise and medications. And then if symptoms get bad enough, it can be treated with procedures and surgery. However, the onus is upon the patient to kind of work through this chronic condition over a long term.
All righty, let's change tactics a little bit. Let's talk about the risk factors for PAD.
So there are several potential risk factors for PAD. Probably the most significant is smoking. So patients who smoke, and that could be tobacco or other products, are at significantly increased risk for peripheral arterial disease. In addition to that, patients who have high cholesterol or hypercholesterolemia are also at increased risk for developing peripheral arterial disease. And then diabetes not only is a risk for PAD or peripheral arterial disease, but can complicate the management of PAD as well. These are some of the biggest risk factors that we, as physicians, primary care physicians working with our patients, try to manage. There are other risk factors that aren't maybe as closely thought about. Depression increases your risk for developing peripheral arterial disease. There are patients who are at higher risk for developing PAD based on other factors, and that can be race, socioeconomic condition. These are all potential increasing risk factors for development of and progression of PAD.
And Dr. Khaja, what are the risk factors for atherosclerosis?
So a lot of things, so some of it may be genetic. We all have some genetic predispositions towards atherosclerotic disease, but also your diet can affect this. So increasing trans fats, fatty foods, increasing the amount of red meats that you might eat can contribute. So managing your diet in a healthy way as well as exercise can reduce some of this the buildup of atherosclerotic disease.
And Dr. Patel, what kind of patient might we expect to see in PAD clinic?
The
Gender
typical,
and age.
yeah, the typical patient we tend to see is a male, typically over the age of 65, typically a smoker at some point in their life, or a current smoker. Um, we are seeing more and more patients who are non-smokers, but as Dr. Grossman mentioned, they have other chronic conditions that accelerate their atherosclerosis, like diabetes or end-stage renal disease, for example, dialysis, that also cause them to have similar issues.
And I guess this is for the group. How does smoking impact PAD?
Yeah, so I'm happy to mention a little bit about this. As Dr. Grossman mentioned, smoking is really one of the most preventable causes of a lot of these disease processes. The chemicals in cigarette smoke, especially nicotine, can cause your arteries to narrow, can make them stiffer. It reduces blood flow to the legs, and then it also builds up or speeds up the process of building this atherosclerotic deposits or plaque in the walls, and which again are the main causes of PAD. And then also just smoking as a whole increases inflammation in your body, which can result in the buildup of this atherosclerotic disease or clot. And even if you have an intervention or a surgery, smoking can make all of those things work less well. So really, smoking is the number one thing that we can all do to prevent or to cause peripheral arterial disease. And if stopping smoking or not smoking at all can prevent some of these to some degree.
Thank you. Dr. Patel, what are the common symptoms of PAD?
The early symptoms of PAD are called claudication, which is a long word to say effort-induced pain. Typically, people will start to notice pain or cramping when walking a certain distance. Typically, this is felt in the calf muscles, sometimes in the feet. This pain should definitely get better when a patient rests, and then should reoccur when the patient tries to walk a similar distance or put a similar level of effort into their next activity. As the disease progresses, patients will develop blood flow that's so poor that they get pain at rest, particularly at nighttime when they're lying flat. If it gets even worse, you can develop wounds and or infections that threaten your foot.
Dr. Khaja, what are some common diagnoses that are similar to PAD?
Yeah, thanks, Ann. So we see a lot of patients in our multidisciplinary clinic that have leg pain. And we obviously in our PAD clinic, we're thinking about arterial disease, but there's a lot of other things. So you could have vein problems, keeping in mind that arteries carry blood flow away from the heart into your organs and into your extremities, so into your legs. Veins bring the blood flow back towards your heart. And so if you have an arterial blockage, it can cause leg pain, as we've described throughout this conversation so far. But veins, when they get blocked up or when they're not working correctly, you can still get leg swelling, achiness, and heaviness, especially after standing for a long time. And unlike PAD, vein pain tends to get better when legs are elevated. You can have skin changes and other visible varicose veins that are similar in patients with vein disease. Other things that are very common include arthritis. So you could have knee arthritis, ankle arthritis, hip arthritis, and your leg just hurts. So the more you walk, the more it hurts. You could have other muscle problems like stretches, strains, or tendon problems that can result in leg pain. And then finally, the most other common thing that we see are nerve-related issues. So patients will frequently show up in clinic and they describe their discomfort in specific ways that they may have a sharp shooting pain, which could be a pinched nerve in your back that actually goes all the way down your leg called sciatica. Or they could have neuropathy, where you have numbness and tingling in your leg that makes it hurt. And that can be frequently seen in patients with diabetes. So there's a whole range of other things. And I think that our group really works well together to figure out which thing it is, whether it's a nerve issue, a musculoskeletal problem, a nerve problem, or if it truly is peripheral arterial disease, and then figure out the right course of treatment for you.
Yeah, I find diagnosing PAD often quite challenging. And we try to ask questions of our patients in an open-ended way and let them describe what they're feeling. I would say the vast majority of my patients don't come in and say, I have pain in my legs. They may say, I have some discomfort, some cramping, as was mentioned, some burning. Um, their legs are just sore when they walk, and it gets better when they rest. So we try to let the patients sort of describe their symptoms and then ask some questions to sort out what may be the etiology of the discomfort. And we combine that, as was already mentioned, with non-invasive testing in clinic to try to figure out what's going on. And many of our patients may describe their discomfort in different ways, but using these inexpensive, minimally invasive tests like the ankle brachial index really helps us figure out what's going on.
Yeah, as Dr. Grossman said, I think what we pride ourselves in is taking a holistic approach, asking you what bothers you, and then from there figuring out based off of, as he said, the testing, and what we're hearing from you, what really might be what's causing your discomfort, your pain, your heaviness, whatever have you, and figuring out what's the best way to treat that.
Thank you. Dr. Grossman, how might PAD affect my daily activities or quality of life?
So that's a very important question, and the peripheral arterial disease, as we were just talking about, can certainly cause symptoms, can certainly impair your ability to walk a certain distance. I've had patients whose job required them to walk distances. A mail carrier, for instance, couldn't do his job anymore because of claudication, and that patient had an indication for aggressive treatment of their peripheral arterial disease. But the majority of patients that we see with PAD do have some limitations in their daily activity. It hurts to go walk a certain distance, and so they just choose not to do it. And when they choose not to do it, they don't exercise. Their other health deteriorates as well, and functional capacity can also decline. We know that many patients with peripheral arterial disease, even if they don't progress from leg achiness when they're exerting themselves to the more severe conditions that Dr. Patel described, like the need for amputation, have an impaired walking distance, and impaired quality of life that actually can progressively get worse over time. So aggressive treatment and management, recognition first of all, and then management of PAD is something that we all strive to do. Not just do procedures or surgeries, but treat patients appropriately with medications, and maybe most importantly, exercise therapy to maintain and even improve functional capacity over time to encourage our patients to live in a healthier way, and not be as limited not only by leg pain, but get the benefits of exercise for their cardiac or heart health and lower blood pressure, for instance.
That's a great segue into the next topic of treatment recommendations. So, Dr. Grossman, can you continue talking about the medical treatments for PAD?
So medical treatment for peripheral arterial disease is really a multi-pronged approach, and it's not just from experts in a vascular clinic like ours. Very importantly, we need to partner with your primary care physicians or primary care providers to manage risk factors for PAD. And we mentioned those already, but I'll just reiterate, stop smoking, the most important thing that we can do. We have an excellent smoking cessation program as part of our multidisciplinary PAD program, and we work very hard to get smoking cessation help to our patients. It's important to recognize that the vast majority of patients who smoke and try to quit smoking are not successful the first time, the second time, or the third time, but we need to keep trying, and eventually patients will be able to stop smoking. So that is obviously something that we emphasize in our program. Controlling risk factors, as we talked about, is very important. That includes medical therapy for cholesterol. We're very aggressive in managing cholesterol, and the most effective medications are statins. And most of our patients can tolerate those statins well. Statins not only will prevent progression of peripheral arterial disease, they'll improve outcome if patient needs a revascularization procedure like surgery or a balloon and stent type procedure. They'll also lower the risk for heart attack. They'll lower the risk for stroke. In addition, management and control of diabetes is incredibly important. And again, partnering with your primary care provider, your diabetes specialist, and managing your diabetes is something that can help prevent progression of PAD and prevent patients from having and developing other issues that can exacerbate PAD, like developing neuropathy, which then can lead to ulcers in the foot that can be very difficult to manage. Finally, controlling blood pressure is very important. And again, we want to work with your primary care provider to control blood pressure. So on the medical side, those are some of the things that we can do. There are a group of medications, one medication in particular, that can actually help improve walking distance. And as a medication we very often prescribe in addition to a structured exercise program, and that's called cilostazol. And that medication is very well tolerated. It's generic, and it has definitely been shown to help improve walking distance. And it's something that we very often prescribe to our patients in our clinic. There's been some recent data that's shown us that low doses of a certain type of anticoagulant can not only improve outcome with peripheral arterial disease, it can also improve outcome in patients who've had revascularization. So in many of our patients, we're giving patients a low dose of a medication called Xarelto based on recent clinical trials. Again, those are the medications that we can provide for PAD. I briefly mentioned, but one of the most important things that we do is try to get patients into a structured exercise program. Insurance now covers this for many patients with symptomatic peripheral arterial disease, and it can not only help improve walking distance, but also improve functional capability over time. So patients in a structured exercise program, if they stick with it over a period of weeks, can significantly improve the distance that they can walk without discomfort. And that in and of itself may be enough to eliminate the symptoms of peripheral arterial disease that are impacting a patient's daily life and allow them to go back to doing things that they want and need to do. And that could be shopping, playing with their grandchildren, continuing to work. In addition to that, we partner very closely with our colleagues in podiatry. Foot care for patients with PAD is extremely important because we want to prevent patients from developing ulcers or wounds on their foot or even blisters. Any patient who has significant peripheral arterial disease should see a podiatrist, potentially have the podiatrist help with nail care as well. And if a patient develops a wound or an ulcer, we get them in to see our podiatry colleagues and or the wound clinic or both to aggressively manage that wound and prevent progression of disease that might unfortunately lead even to the need for a procedure or an amputation. These are some of the things that we do to manage peripheral arterial disease that don't involve surgery or revascularization. And I'll turn it over to my colleagues to talk a little bit more about other ways that we can manage more advanced peripheral arterial disease.
Yeah, so that was great. So everybody that we see in our clinic gets medical management, as Dr. Grossman discussed. Dr. Khaja, can you speak to endovascular opportunities?
Sure. So Dr. Grossman gave a really good rundown of the medical management, and endovascular revascularization, or improving your blood flow, or another way to call it is catheter-based treatments, involves doing a procedure. So it is coming into the hospital. It's having a procedure where you're sedated or kept comfortable during the procedure. We map out your arteries by doing an angiogram. Those are some of the words that we use. But that's just us injecting dye into your arteries, evaluating the blood flow, looking at sort of how your body has redistributed that blood flow, maybe through collateral arteries. And then once we figure that out, what we can do is do an angioplasty or ballooning that artery open to create more space. Sometimes that involves just sort of smashing that atherosclerotic disease or that cholesterol to the side, increasing the lanes on the highway, I like to think about it. Sometimes we place a stent, which is a piece of sterile metal that sort of holds that open. I think of that like repaving the road on the highway, and improving blood flow down to the arteries below. The other ways that we can do that is use adjunctive tools. We have lots of tools in our toolbox in this space. We have balloons that have a medication on them that can slow down the progression of disease and reoccurrence of disease. And then we have other tools that can help break up calcium, which is frequently formed on atherosclerotic plaques or cholesterol. So you can get cholesterol, and on top of that, your body forms calcium. We have tools that can break that up a little bit. And then also ways that we can almost shave off a little bit of that cholesterol in your arteries to create more space. And again, I think of it like highway traffic. So if you had 4 lanes on the highway and the cholesterol takes up 2 lanes, we can maybe get you back to 3 or even 4 lanes by doing some of these different techniques. And so our goal is to improve the blood flow down your legs in a minimally invasive way that can sort of improve your health, get you out of the hospital in a quicker fashion so you can get back to your life. These procedures are frequently done in a couple of hours, and then we kind of sometimes keep you overnight. Sometimes you go home the same day, and then you can kind of get back to things. But we want to make sure that after we do one of those procedures, that we follow you up. We make sure that your medication management, as Dr. Grossman mentioned, is up to the right level. And if you should need a surgical management, which requires a little bit more aggressive treatments, that you are set up for that. And I think Dr. Patel will talk a little bit more about those options.
Yeah, Dr. Patel, can you talk to us about surgical options to treat PAD?
Yeah. So when endovascular options fail, or there is no good or durable endovascular option, we turn to surgery. That can take many, many forms, and that's dependent on what is blocked, where it's blocked, and how bad. Sometimes we can do something called an endarterectomy, where we open up a blood vessel itself, remove the plaque, and close the blood vessel back up. Sometimes we have to do a surgical bypass, where we use a tube of some sort, whether it's your own vein or a plastic tube, to redirect blood flow around a blockage if it's too long to endarterectomize. In addition to that, we can employ hybrid techniques where we form some of the open part as well as employing a stent or a balloon in another part at the same time to improve flow in multiple regions. All of these are, once again, based on your specific anatomy and your symptoms. The worse your symptoms, the more aggressive that we would be. And just like Dr. Grossman mentioned earlier, the outcomes for these surgeries are greatly impacted by the risk stratification or risk factor modifications that you guys have made leading up to this, whether that's smoking cessation, diabetic control, and continued exercise afterwards. Those all help allow for whatever we do to last longer. Sometimes you require repeat surgery, repeat endovascular options, and every time we do another surgery, another stent or balloon, we can lose that option moving forward. We burn our bridges. And so good risk factor modification is imperative if we're going to go down any of these pathways.
Yeah, I think we mentioned at the outset talking about peripheral arterial disease and thinking about it as a chronic condition. And revascularization is certainly something that we can do. But as was mentioned, it's not a cure for peripheral arterial disease. PAD can recur, it can be progressive. And so we need to do everything we can with medical therapy to prevent progression of disease. In addition to that, in our program, we're very diligent about follow-up of our patients. So once you see us in clinic with a diagnosis of peripheral arterial disease, we want to follow you over time. If you have revascularization, as was mentioned, we want to follow you very closely after that revascularization. And if there are issues that pop up, we want to catch those earlier rather than later. So potentially we can do a relatively minor procedure to improve blood flow, as opposed to waiting too long and have a blood vessel close all the way, and then we have a real problem that might require a much more extensive procedure or even a surgery to fix. And Dr. Patel, as a vascular surgeon, would also follow any bypasses that are done very closely in a similar fashion. So once you're in a multidisciplinary PAD program like ours, we get to know each other pretty well. And Anne and our team follow our patients very closely and are always available if symptoms change or progress. We want to hear from you.
It's a longitudinal partnership where we help care for you and make sure that what we've done provides you the best benefit long term.
We do have an audience question, so let's just take a couple of steps back. They would like to know, how do you tell if your leg pain is related to arterial disease or nerve problems?
So I'm happy to offer a little bit of shed a little light on this. So we mentioned earlier that we really want to get a thorough history. We want to understand from the patient how their pain feels or their discomfort or how it's affecting their life. And sometimes when we're sort of having this conversation with our patients, we're able to figure out, how it feels and when the onset of the pain is. And that can help us determine whether it is really related to an arterial problem or a nerve problem. Artery pain sometimes comes on with usually comes on with increased activity. And then when you take a break, it gets better. So it feels like a burning pain in your calves or your thighs. And then you take a break for about 10 minutes or 5 minutes or 2 minutes, and it goes away. Nerve pain feels a little bit different. It might be a sharp shooting pain. It may feel like numbness and tingling. It may start in your toes and move its way up. It may feel better when you bend over more. We frequently find out from our patients that we have a common question. We ask, hey, when you're in the grocery store, do you feel better when you're pushing a cart, or do you feel better when you're walking without a cart? And sometimes if you're pushing a cart, that actually opens up the spaces for your nerves. And so we can kind of elicit what is really provoking that pain. The other thing is that we do those non-invasive studies. And so doing the ankle brachial index, or the ABI, really gives us an idea if there is a blockage somewhere in your arterial system. And so if you have these types of symptoms and your ABI is completely normal, we have a good sense of whether this is really related to arteries. I open it up to Dr. Grossman or Dr. Patel for other thoughts as well.
Yeah, I think it's very important that you talk to your primary care provider about your symptoms. If need be, get a referral to a vascular specialist to diagnose hopefully what's going on. We have had patients who end up in the PAD clinic who've been sent to an orthopedic surgeon because it was thought that they had needed a knee operation or a hip replacement, and actually what they had was significant peripheral arterial disease. And sometimes just taking a good history, talking to the patient, and combining that with non-invasive tests can be very helpful. There is one non-invasive test that we do that can really help us unmask peripheral arterial disease. If a resting ankle brachial index is normal and we have an index of suspicion that there is something going on, we can actually have a patient walk on a treadmill and then measure their ABIs again. And for patients who have disease in certain locations in their arterial system, so-called inflow disease, we see the ABIs drop. The blood flow to the legs at rest is really quite low. But when we exercise, the blood flow to our legs can go up 10 or 20-fold. And that's when symptoms can be unmasked if there is impaired blood flow to the lower extremities. So some of the tests that we do in our clinic and in our vascular lab help us really understand what's going on, make a diagnosis, and then come up with an appropriate treatment plan.
Thank you. Um, so just because lifestyle changes are so important, I want to talk about them again. So Dr. Khaja, how effective are lifestyle changes in managing PAD?
Yeah, so I think we've all sort of discussed this, but as Anne mentioned, it's really, really important. Regular exercise with walking, cycling, swimming, riding a bike, all of those things help improve blood flow and reduces leg pain by building new blood vessels around those blockages. Supervised walking programs are really effective. There have been lots of studies, including randomized controlled trials, that have shown that by having a structured exercise program, you're able to walk further and faster and experience less pain. Other things, again, we can't reiterate, quitting smoking or not smoking really can help. Quitting greatly reduces the risk of a heart attack, stroke, and an amputation, some really negative downsides of vascular disease. And stopping smoking immediately can slow or even halt progression of PAD. And most people note better circulation and improved healing after they quit. Other things that, again, that you can do, having a heart healthy diet, a diet rich in fruits, vegetables, whole grains, and healthy fats rather than the bad fats like saturated fats or trans fats, high salt, and increased sugar can reduce inflammation and improve blood vessel health. And so these all overall promote heart healthy changes. And then finally, reducing stress and other risk factors, controlling your diabetes, managing your weight. All of these things can significantly impact your health, make you feel better, get you on your feet, do the things that you want to do in your life.
Great, thank you. We have an audience question. Does smoking marijuana affect my arteries?
There is some data that smoking of any kind increases the risk of peripheral arterial disease. So we do not recommend smoking marijuana in our multidisciplinary PAD clinic and try to help patients quit smoking of any kind.
Thank you. Dr. Grossman, why is cholesterol management so important?
So at a very basic level, peripheral arterial disease is essentially buildup of cholesterol in the walls of the arteries or the blood vessels that are feeding blood to our legs in PAD. And so medications, medical therapy to reduce cholesterol level can slow progression of PAD. There is some data in coronary artery disease that aggressive management of cholesterol can actually lead to regression of coronary artery disease or improvement in atherosclerosis just by taking a good dose of the statin medications. And certainly, again, in PAD, we've got good evidence that it helps slow progression of disease. And if a patient has a revascularization procedure, being on a cholesterol managing drug before you have that revascularization procedure improves outcome. So the procedure is more likely to be successful, and the benefits of that revascularization procedure are more likely to be sustained over a longer period of time. In addition to that, obviously, lowering cholesterol lowers the risk for other vascular events, such as a heart attack or a stroke. So overall, if you have peripheral arterial disease, again, you probably have buildup of atherosclerotic disease or cholesterol in the walls of your arteries, in your heart, and potentially in your brain or in the carotid arteries, which feed blood to the brain. So we want to control cholesterol very aggressively in our patients with peripheral arterial disease to lower the risk of not only vascular events, but lower the risk of stroke and heart attack.
What are the side effects of statins?
That question comes up a lot, and the most common complaint patients have who are on some of the statin medications is they get achiness in their muscles, and this isn't just my bicep hurts once in a while. This is more like achiness all over, like you felt like you just worked out for the first time in 3 years, and it's that kind of muscle achiness that patients often complain of. And we try to work with patients, first of all, to sort out if what they're experiencing is related to the statin. And then very often we can change doses of some of the statin medications or change to a different cholesterol medication that's not associated with that side effect, which can be very limiting for some patients.
And what do we typically recommend if patients are allergic to statins?
So most patients who are quote allergic to statins are intolerant to the statins, and again the most common symptom is the muscle aches. And then there are other non-statin cholesterol lowering medications that can be used. Generally, those are prescribed by a lipidologist or an expert in cholesterol. Sometimes endocrinologists, primary care providers can prescribe some of these medications. There are other pills that can be tried. In addition to that, there are even injectable medications that have been shown to effectively lower cholesterol and lower the risk of cardiovascular events. So we work pretty hard on managing cholesterol in our patients with peripheral arterial disease. We have a lot of medical therapies that are potentially quite effective. As was mentioned, I think a couple of times already, obviously, lifestyle modification, heart healthy, low cholesterol diet can also be very helpful in lowering cholesterol, as can exercise. So all of these things are very important in lowering cholesterol and potentially lowering risks for future vascular events.
Dr. Patel, can you talk a little bit about exercise and a walking program?
Yeah, and I'll borrow Dr. Khaja's highway analogy for this. So a walking program helps PAD symptoms by helping to build collateral vessels. So essentially, think about Dr. Khaja's highway that's going down. It's 4 lanes, now it's 3 lanes. Cars start to use the service road instead of trying to deal with the traffic. Collateral vessels are like service roads, and our goal with the walking regimen is to build more and more service roads. Now, one service road is a single lane road with lights on it, and so that's not going to get very many cars down. But if you can build 3 service roads or 4 service roads or whatever, you can increase the amount of cars that can get past that amount of traffic. And even if your highway's down to 1 lane, if there are other service roads that can help out, well, now you're still getting blood to your legs. So a walking program helps build those side roads. And I wanted to take a second to define a walking regimen, because you don't necessarily need to have someone tell you or watch you do this. Anyone can do this on their own. It is simply walking. However, it is walking with the intention to walk past the pain. For some people, that means 1 mailbox down the road. For some people, that means 30 extra seconds on a treadmill. For some people, that means 1 extra step every single time you walk. As long as you're walking past the pain, you're sending a signal to your body that they need to build those collateral pathways. The other thing that makes this hard, not only are you stressing yourself and essentially working out, but you need to do this regularly, day in and day out, without missing long periods of time, because the collateral pathways require a constant signal to be built. And so just doing 1 day of walking a week or something like that is not going to do enough. You need to do it 3 to 4 times a week without missing more than 1 day at a time. And finally, a lot of people will say, well, I went to the grocery store today. Does that count as my walk? And I would tell them no. I would say that regular activity, doing all the stuff that you normally do in your daily life, is just what you do. A walking regimen should be intentional. You are spending 15, 20 minutes only on walking, only on the intention to walk past the pain, and make that a part of your routine.
Are there other exercises that are as equally beneficial?
I think walking has been the best that's been studied, but any cardiovascular exercise is going to be important. If you can't walk because of joint pain, swimming can be helpful. If you have trouble with balance, then stationary bikes can be helpful. Anything to improve your cardiovascular fitness, I think is something you should try.
Yeah, I'd also add that walking past or through the pain is important, but then stop, rest, pain goes away, and then walk again. And build yourself up over time in a walking regimen, and as Dr. Patel said, a dedicated amount of time, 15, 20 minutes at least a day is ideal. And over time, patients find that they're able to walk further without pain after a few weeks. And then if they continue that walking regimen, those gains can be maintained. If for one reason or another they stop their walking program for an extended period of time, they may lose some of the gains that they made in their walking program and have to go back um, uh, uh, and sort of start over, if you will. But again, over time, as was mentioned, the walking program certainly helps build collaterals, and it also helps our muscles be more efficient in how they use energy, get stronger, and therefore, again, improve walking time and functional capacity and really maintain quality of life. And this has been really well studied in many studies of exercise therapy for peripheral arterial disease.
Thank you. I really like the highway analogy. Dr. Patel, what are the potential complications of untreated PAD?
Yeah, so this is kind of where we get to some of the scarier kind of topics. So when we think about untreated PAD in the legs, and I think Dr. Grossman mentioned this earlier, this is a chronic kind of holistic problem that's happening everywhere in your body. But when we're thinking about it in the legs, our main concern is limb threat. This can present in a couple different ways. One is rest pain, so pain when you're kind of not even using your muscles. Your perfusion to your legs is so diminished due to multiple blockages and or narrowings that even at rest, when your muscles aren't requiring that 10 or 20-fold blood flow, they are in pain. One stage further is non-healing wounds, so ulcers or blisters that do not heal. Gangrene can set in, infections can set in, and this can ultimately threaten your foot and put you at risk for amputation of toes and or your leg.
Are there any guidelines that you use to recommend amputation?
So we recommend amputation in a few different scenarios. I think if there's a wound that has become so bad that there's no chance of salvaging it, even in the setting of improved blood flow, that's one reason to have an amputation. If there's an infection in your foot that is threatening your life, that would be another indication. And finally, and sometimes the worst one, is if we've simply run out of further options because the disease has progressed to such a degree that there's nothing else that we can do, whether it's open surgical bypass or hybrid and endovascular options.
I'd also add that I think sort of the most advanced forms of PAD that may lead to the need for amputation, I think about them in two big buckets. One, as was already mentioned by Dr. Patel, is sort of chronic progression of disease, rest pain to ulcers that don't heal, to eventually potentially infection. But that there's another type of peripheral arterial disease, which is more like a heart attack of the legs, if you will, where there's an acute closure of a major blood vessel feeding the leg, and the leg can become acutely ischemic. So patients can go from feeling normal to severe pain in their leg, difficulty potentially moving their leg, and that's a vascular emergency. It's called acute limb ischemia, and that patients who have those symptoms need to be seen in an emergency department and immediately evaluated by a vascular specialist to try to save their limb, if not their life. So any patient who even has mild or moderate PAD. If they develop acute, severe leg pain, numbness, loss of motor control, call 911 and get to an emergency department as quickly as possible for vascular evaluation.
Thank you. That's a great point. Dr. Khaja, what are some advanced revascularization therapies?
Yeah, so as I mentioned earlier, we have a lot of tools in our toolbox. And as Dr. Patel mentioned, we have some surgical options, we have some endovascular options. But nowadays, we actually have new innovative techniques that almost combine both into one. So we talked a lot about cholesterol and reducing that cholesterol, opening the lanes on the highway, if you will. So we have things like atherectomy devices. And what those do is, they shave off some of that cholesterol plaque, creating more space. We even have things like lasers, believe it or not, on a catheter that sort of photoablate or sort of wipe away that that cholesterol. There are other techniques. There's some devices. There's a device called LimFlow, which is basically a percutaneous surgical bypass. So it doesn't require open surgery with a cut, but rather we're rerouting blood flow from an artery quickly into a vein and back into an artery for a short segment in order to get blood flow down your leg. And then finally, we have performed procedures here called deep vein arterialization. And this is in patients who really have very poor arteries for a long segment of their arteries. And what we were actually doing is rerouting blood flow from the arteries itself into your veins in your feet in order to get oxygenation and nutrients to the poor quality tissue or to areas of infection that need better flow in order to heal. And so we have really all of these options available to us and to our patients. And we frequently talk about these patients with our whole team, including our surgeons, our cardiologists, our radiologists, to figure out what might be the best option for these patients and for our patients, and really sometimes employ multiple different techniques. So, and what's really interesting in this field is that there's newer and newer technologies coming out every week, every month, where we can really try to find good ways to help our patients.
Thank you. So I think the takeaways from today's show are that PAD is a chronic disease, and managing it medically with lifestyle modifications is really important. And then as needed for symptom management, we can do revascularization procedures, either endovascular or surgical, to help patients improve their quality of life and functional ability. We have about 5 minutes left before we finish. Do any of our experts have any closing thoughts or remarks?
I'll just start by saying, this is really great that we're doing this. We hope that this has been helpful, informational to everybody who's watching. I know it's been a great opportunity for me. What I will say is that what I think sets our program apart is that we work together. We have 3 different specialists and Anne as our quarterback/point guard, sort of helping direct all of our patient care. And our goal is not to do procedures, not to do surgeries. It's to take care of the patient and make sure that we can figure out all of the different options that we can present to a patient. We want to ensure that you're doing your part, and we're definitely going to do our part.
Yeah, I'll just add that we've tried to build our program in a way that patients can get with one visit to our clinic the benefit of testing when needed, obviously medical therapy and a diagnosis, and then a treatment plan that we will employ with our patients to give them the best outcome for not only their vascular disease, but for their heart, prevent a stroke, and maintain functional capacity. And then very importantly, we follow our patients longitudinally. So we want to continue to see you in our clinic. That can be in face-to-face visits. Sometimes that can be virtual visits with appropriate testing when needed to, again, make sure that patients maintain the improvement in their symptoms of PAD over time. And if there are issues, we catch them early and we can treat them much more successfully. The cornerstone of our program, though, is medical therapy, exercise therapy, help quit smoking, and get good foot care.
To close out, I want to just give a shout out to Anne Luciana, who is really the engine of this PAD program. And like Khaja said, as the quarterback, she kind of sits in the middle of it, and she will see patients at any given time, and she's able to help direct them to the appropriate lipid clinic, to the smoking cessation programs, and to one of us for an intervention if needed. A thing that makes this program unique is that we meet regularly. All four of us here today meet regularly to discuss patients, which I think is something you don't necessarily see in a lot of different programs. When you have three subspecialists work together, looking at images together to understand what the best treatment option is for their patient. And that's something that we provide on a regular basis.
Thank you. And so we have some resources for you that we will put in the chat. Some guidelines for PAD that just came out in 2024, and then some online support for patients if you want any further information. I think that finishes our live stream today. We appreciate you coming to watch us, and please share this link for the video with others if you think that's appropriate. Have a good evening.
Thanks, everyone. Thank you very much, Anne.
Thank you all.